Hello, my name is Kevin Mosio, and in today's video, I'll be highlighting our recent work, Exercise-Based Stroke Rehabilitation, Clinical Considerations Following the COVID-19 Pandemic. Like many areas of healthcare, the pandemic has led to significant changes in the delivery of stroke care, including significant reductions in stroke medical service delivery and limited offering of in-person and center-based activities. Unfortunately, there was no guidance explicitly focused on stroke rehabilitation. This is important given that up to 5 million COVID-19 cases will present with a new onset cerebrovascular event. Best practice guidelines endorse stroke rehabilitation programs for improving health post-stroke. There is strong research supporting exercise training as a recommended component of stroke rehabilitation, and it's effective for improving functional recovery, cardiorespiratory fitness, and markers of neurorecovery. But because of the COVID-19 pandemic, clinicians are now facing challenges with the implementation of exercise training and stroke rehab. To develop our clinical considerations, we first need to explore the multi-system pathophysiology of COVID-19 related to stroke and exercise. I'll also highlight the potential benefits of exercise for individuals post-stroke with COVID-19, and I'll provide a brief overview of our clinical considerations related to COVID-19 for exercise during stroke rehabilitation. In these next few slides, I'll be taking you on a journey through the pathophysiology of COVID-19. It is well known that the COVID-19 virus is transmitted through respiratory and aerosol droplets. As the virus enters the airways, it binds to ACE2 receptors on nasal epithelial cells. This triggers a cascade of events leading to cytokine storm, a detrimental cycle of an exaggerated release of circulating cytokines. This leads to systemic inflammation and multisystem dysfunction. Importantly for stroke recovery, the multisystem effects of COVID-19 may be more pronounced amongst individuals with stroke, who may already demonstrate cerebrovascular and cardiovascular dysfunction, decreased lung function, and musculoskeletal impairments. Which brings us to this question: how can exercise help improve or mitigate the multisystem dysfunction of COVID-19 in people with stroke? From a clinical perspective, exercise training may counteract and improve the multisystem effects of COVID-19 for people with stroke. In the stroke literature, there's data to support that exercise training may improve markers of neurorecovery and pulmonary function, and there is strong evidence supporting improved cardiovascular function, reductions in cardiovascular risk, and gains in functional capacity like mobility and muscle strength. In the absence of stroke-specific guidance, we developed an international group of experts in stroke rehabilitation, exercise physiology, and neuroscience in Canada, United States, and Europe to develop clinical considerations for stroke rehabilitation. First, we would like to acknowledge that the COVID-19 situation varies significantly from region to region. Thus, our considerations must be considered in the context of local public health guidelines. Nonetheless, it is important to monitor the onset of new symptoms using the COVID-19 pre-participation screening questionnaire that we have developed in this paper. This questionnaire can help identify potential respiratory, cardiovascular, neurological, and musculoskeletal effects of COVID-19 that might be contraindicated by exercise. We have also developed an evidence-based COVID-19 decision-making algorithm for pre-participation screening and eligibility for exercise rehabilitation. This algorithm helps identify whether someone with stroke is eligible for exercise rehabilitation and the steps required based on COVID-19 symptoms and status. It can also assist with clinical decision-making about whether further medical assessment and/or exercise stress testing with ECG is required before engaging in exercise training. In summary, up to 5 million people will suffer from stroke after COVID-19 infection. This means that up to 5 million people are needing exercise-based stroke rehabilitation. Our considerations incorporate the best available evidence in exercise physiology and clinical judgment and stroke rehabilitation to guide the implementation of safe exercise prescription so that people with stroke can reap the benefits of exercise and mitigate the effects of both stroke and COVID-19 infection. I'd like to thank all co-authors for the support and to NNR for publishing this work.